1917 that anyone who used nutrition, herbs, homeopathy, or electromagnetic therapies would lose their license to practice, which at that time was granted by the AMA. And the Flexner report came out in 1910, and in 1917, the AMA got rather more serious about it, and by 1934, it just came down and they shut it down. So by threatening physicians with the loss of their licenses. So the frequency and electromagnetic therapy machines went into the back rooms of clinics and got covered up by a sheet. All of the journals, like they had journals, Electromedical Digest and the Pathometric Society. There were others, but those are the ones that I know about. Those journals went away. The physicians who developed the frequencies and used the frequencies, when that generation of physicians died out, all that information was lost about where the frequencies came from and how they derived them and all of that. So I came about the list of frequencies because I know somebody, George Douglas, worked with an osteopath named Harry Van Gelder, who was a naturopath and osteopath from England, who, after World War II, he bought a practice in 1946 that came with a machine that was built in 1922, and that machine came with a list of frequencies. So Harry walks into this clinic that he just bought, this practice that he just bought, and walks around the clinic, and there in this back room, there's this wooden box with knobs and dials and copper electrodes with a sheet over it. Takes the sheet off, looks at it, it's like, wow, what's this? And the machine, in a drawer on the table under the machine, there was a list of frequencies. So the list was fairly simple. There was a list for conditions, things like inflammation, infection, scar tissue, fibrosis, chronic inflammation, toxicity. There was those words, so inflammation was on the page, and 40 hertz was written next to it. Fibrosis was on the page, and 51 hertz was next to it. So that was in 1946. He began using the machine in his practice, and became renowned, famous. He had amazing results throughout the western half of the United States and Canada. And George Douglas went down and worked with him in 1981 and brought the list of frequencies back and basically stuck them in a drawer. In 1992, the Precision Micro came out, and George bought one and didn't use it much, but he kept the list. And in 1994, I graduated from chiropractic college, and in 1995, George stumbled across, found the list in a drawer, and said, hey, there's a list of Harry's frequencies. You know, that microcurrent machine I bought a few years ago has 2 channels like Harry's old machine. I wonder if the frequencies would work on the microcurrent machine. Well, we could try it. So in 1995, we started using the frequencies on each other, my kids, on a few friends, and then I started using them in my practice, treating fibromyalgia and chronic fatigue patients in 1995. I graduated from chiropractic college in 94 at the age of 47. 95, I worked with George. He kind of taught me how to look at the list and how to use it on patients. 96, I started using it to treat myofascial pain. And by late 96, early 97, we decided that I had to teach it to find out if it was reproducible, because we were doing things in myofascial pain with trigger points that are basically impossible to do. So I we decided that we were going to teach it. So in January of 1997, 20 years ago now, I taught the class for the first time, and the class was terrible. I taught a lot about old-fashioned kind of non-specific microcurrent. I wasn't really confident in what we were doing with the frequencies. I didn't teach it well. The class was pretty awful by today's standards. But people persisted. There were 25 people or so in the class at NCNM at the Naturopathic College in Portland. And by June of 97, we found out that it was that the frequency responses were reproducible. That's my dog. Came up to see what we're doing. So by June of 97, we knew that the frequencies were reproducible. At this point, I honestly don't know how the frequencies were derived. How did somebody in 1910 or 1917 decide that 191 hertz was the frequency for the tendon and 195 hertz was the frequency for the bursa? How did somebody decide that 396 hertz was the frequency for the nerve? There's absolutely no logic to or order to the frequencies. How did they figure it out? Honestly, that information is lost forever, because once those men, mostly men, died out in the 30s and 40s, it's gone. We don't know what they did. There are old journals in the rare book room at the Naturopathic College and at probably old medical schools. The old devices are actually found in the Quack Museum, which I find pretty hilarious. The Quack Museum, I think it's in Chicago, because the AMA decided that the frequency and resonance therapies that were used in the early 1900s, they decided that they were invalid. So when Abrams, he was an MD who practiced in San Francisco, he was treating all sorts of conditions with frequencies. And Upton Sinclair, who wrote the Jungle and did this big expose on the Chicago meatpacking industry, Upton Sinclair was sent out to San Francisco to expose Abrams as a fraud and a quack. He was sent out there by the American Medical Association in 1921 or 22. And Sinclair got on the train, went to San Francisco, went to Abrams' clinic, and we have copies of letters that Upton Sinclair wrote back to the AMA where he said, I know you think this guy is a fraud, but there's something real here. He's helping people, and it works, and you really ought to study his methods. And we have a copy of the letter written by the AMA that says, we know this man is a quack, and if we study his methods, we will just validate them. So that's where it went. And in 1922, Upton Sinclair wrote an article for Pearson's magazine titled House of Wonders, and it was about Abrams' clinic in San Francisco. So if you look up Abrams on the internet, Wikipedia, he'll be listed as a fraud and a quack because he didn't have a medical degree. Well, nobody had a medical degree when Abrams went to med school. In Austria, he went to school in Vienna, was trained in medicine in Vienna. Nobody had a degree, and there were no medical schools. So I would recommend that you look up the House of Wonders on our website, frequencyspecific.com. I think it's listed there, and if it isn't, it will be there by tonight. So we're not sure how the frequencies were derived. How did they come up with this list that Harry found in 1946 that came with the machine that was built in 1922? And we're uncertain of the mechanisms of action, although you'll see in a little bit that those mechanisms are a little bit better understood. I can tell you that the 1920s equipment was not microcurrent, it was DC current. It plugged in the wall. When the wall current was direct current, kind of like batteries are in a microcurrent device now. So how is FSM a tool for you, either as a patient or as a practitioner? There are old problems in medicine that are hard to deal with. Healing injuries takes time, and they don't always heal quickly or comfortably. There are certain injuries from surgery and from wounds and from trauma. So the repair limitations in natural healing, unassisted healing, ATP production. ATP is what your body uses for energy. How do you increase the amount of energy that your body has to create repair after surgery and wounds and injuries? How do you increase the blood supply to that repair tissue? How do you increase collagen and elastin? These are the limitations. These are the things that limit the healing of injuries and surgeries and wounds. Well, you have to ask yourself, ATP production is what your body uses for energy. So what do you think would happen to healing if you could increase ATP or energy production in cells by 500%? Well, we know that microcurrent, just the current by itself, just DC current, between 10 and 500 microamps, increased ATP production by 500%, that is by 5 times, and that is duplicated. That was done by Nok Chang in 1982. It was repeated by Seegers in 2002 and in 2001. There are 3 papers showing exactly the same response, that ATP production increased by a factor of 5 times in 30 minutes of microcurrent application. When you get above 500 microamps, so between 500 and 1,000 microamps, ATP production levels off, and above 1,000 microamps, ATP production actually drops. So all of the kinds of current that we use, TENS devices and Russian stim and anything that uses milliamperage current or current above 1,000 microamps will reduce ATP production. So the microcurrent, current by itself, increases ATP production by 500%. That increased protein synthesis by 70% in Nok Chang's paper. That increased amino acid transport by 40%. That's a half again increase in amino acid transport, which is what it takes for your body to repair tissue. Seegers found that it increased the current by itself, increased cyclic AMP in human lymphocytes, that's in vivo, so it's in human white blood cells, and that the current by itself activates signal transduction, or the communication between cells is amplified by the application of current that stimulates cell membrane receptors. So that's just the current. Now, the thing about microcurrent is that it's approved in the category of TENS devices, which are prescription. Now, it's prescription device. It is approved as if it was a TENS, and there's a little bit of a problem with that, and that's because it's not a TENS. TENS has 1,000 times more current than microcurrent. TENS devices work by causing muscle contraction and a lot of stimulation of sensory receptors and muscles, and TENS just blocks ascending pain messages going up the spinal cord and blocks pain. It doesn't do anything for the local tissue. So it's approved by the FDA in the category of TENS, but it is millionths of an amp. It is 1,000 times less current than TENS, so it's not actually a TENS. It is approved for aesthetic use by skin care professionals and estheticians for wrinkles in your skin, and that is a non-prescription use. But you can't make any claims about pain or anything if you have a device that's approved as a TENS, for aesthetic use. Microcurrent, because it's approved in the category of TENS, is billed as a TENS. So for those of you that are in practice, you'll find that you can bill for microcurrent as a TENS device as long as you have a pain diagnosis. Microcurrent devices have been out since the 1970s, early 80s. They vary widely. There's direct current pulse direct current, there are different waveforms: square waves, sine waves, ramped square waves, tsunami waves. There are one-channel devices, single-channel devices. There are two-channel devices. There are combined units where you can get ultrasound, interferential, galvanic, and microcurrent, but normally it only runs 1, 2, or 3 frequencies. And the frequency is generally not important. It's either a very limited number or a sweep of frequencies. It's only after we started, we happened to stumble upon a 2-channel microcurrent device that gave you the ability to use frequencies specifically on each of 2 channels, that the frequency became important, and that was in 1996, 97. So what does the current do in tissues? Well, this study was done at University of Washington. It's unpublished data because it was done for a skincare company. And estheticians don't care about peer-reviewed papers, so this was never published. It was done by some graduate students in the Animal Studies Department at University of Washington. It's rabbit biopsies. So they ran 20 days of microcurrents. They put the bunnies on conductive pads, front feet, back feet, ran the current through the bunnies. They biopsied the bunnies at the beginning of the month. They ran current an hour a day for 20 days, so 5 days a week for 4 weeks. That's what you do when you're a graduate student that needs a paper to be published. And at the end of 20 days, so at the end of a month, it was 20 treatment days, but it was 30 days out of the month. Vascularity, or the blood supply to the bunnies' tissue, had increased by 39%. Collagen had increased by 14%. That's these little black lines here. And elastin had increased by 48%. Now, the trick with wound healing is that scar tissue is not elastic. It is tough. It's collagen. It's repair tissue, but it's shorter and it's tougher, and increasing elastin is tricky. So anything that would increase elastin would be helpful in encouraging normal wound healing. So here's a question. What would happen to injury and wound healing outcomes if you could increase ATP production, increase vascularity, increase collagen and elastin? So that's what has happened with just plain micro-amperage current. We have that data. It increases ATP production by 500%. It increases vascularity by, what was that, 38%, collagen by 18%, and elastin by 48%. It's pretty extraordinary. So the frequency effect makes a huge difference in the healing. Unmodulated, plain old current increases ATP production, elastin, collagen. But the frequencies add an additional dimension to healing and tissue repair that makes a huge difference. So we actually have a controlled trial demonstrating this. Delayed onset muscle soreness is what happens when you work out really hard and the next day your muscles are sore, and the day after that they're even worse, and the day after that they're getting a little better, but they're pretty awful. So this was a control trial where there was one leg that was a placebo device. The machine was turned off. One leg that was an active device. And compared frequency specific microcurrent to a 1999 study done by, oh, come on, what's her name? Allen. 1999 study done by Allen that showed that single channel microcurrent with 0.3 hertz and 30 hertz for 20 minutes had absolutely no effect. It was equivalent to placebo in the treatment of delayed onset muscle soreness. So in Denise Curtis's study, the frequencies that were used were 18 and 62, which we think of as stopping bleeding or hemorrhage, torn and broken, and the muscle belly, the fascia, and the tendon, reduce inflammation in general, reduce inflammation specifically in the muscle belly, the fascia, and the tendon, and then increase vitality. So the treatment time was exactly 20 minutes, the same time that Allen's non-specific microcurrent was used. And this is what happened. So the treated leg, baseline, all patients had no pain. The sham leg at the end of 24 hours, the pain level was a 5 on a 0 to 10 scale. The treated leg was a 1.3 on a 0 to 10 scale. The sham leg at 48 hours was a 7 out of 10, which is really pretty crippling. And then the treated leg was a 1.2. At 72 hours, the sham leg was a 4, and the treated leg was a 0.7. The p-value, it's a measure of statistical significance, was 0.0005 at all time measures, which is extraordinary. It's extraordinary. It means there's absolutely no possibility that these results were a matter of chance, so that they're not correct. The thing about delayed onset muscle soreness is there is no other effective treatment. So if people are athletic or beginning athletes or beginning an exercise program or likely to have any sort of muscle injury, if you run frequency specific microcurrent, the delayed onset muscle soreness protocol, immediately after the exercise, that you won't be sore. And that means that you can play effectively, practice again, and work out again without having to wait 3 to 4 days for the pain to go down. And this would be why we have devices with 1, 2, 3, 4, 5, 6, 7 NFL teams and over 200 NFL players that are being treated by FSM practitioners. So injuries, like sports injuries, wounds, and post-operative outcomes. So this was done by John Cale, who's an MD. These are in patients who had C-sections, abdominal surgeries, and the FSM treated patients were out of the hospital a third of the day. So the patients, the controlled group, the placebo group, the group that was treated with just standard of care for hospitals, got out at 3 1/3 days. The FSM patients got out at slightly less than 3 days. Some patients got out as soon as 1.5 to 2 days after the surgery. Reducing post-op pain is important for getting the patients up and moving. So pain level in the FSM group was like less than a 1. Pain level in the control group, which was treated with just medication, was a 1.8. They try and keep their pain down around a 2. When the patients got up and moved around, their pain level went to a 5 in the control group. These are patients who weren't treated with FSM. Pain level is a 3. You can have a life at a 3, 2.7 with activity. So this means that FSM, the use of FSM postoperatively improves post-op outcomes, reduces pain, and increases the ability of the patient to move and become more active and recover more quickly. So this is the postoperative. And then wounds. We talked about wounds. Well, this is what happens when you treat a diabetic ulcer with frequency-specific microcurrent. See this? I mean, these feet are pretty icky, right? There's a 7-centimeter wound on the side of his left leg, and this wound was healed. You can see this other slide, this other picture, was healed in 6 treatments in 3 weeks, and that's pretty extraordinary. If you look at the end of his second toe, it's necrotic. That is soft tissue and bone under there. It wasn't quite down to the bone, but it's pretty nasty. 9 days later, the necrosis was gone. The tissue is starting to granulate and recover. And 20 days later, it is almost closed up. So that resulted in 7 treatments. This toe resolved in 7 treatments. This toe resolved in 12 treatments. And diabetes, this is extraordinary. This country spends $1.3 billion on amputations alone for diabetes, just the amputations. And basically they were waiting for this wound to get severe enough that it would be worthwhile that they could amputate the toe and possibly the anterior portion of the foot, the distal portion of the foot. That can be prevented. We haven't found anybody that doesn't respond to FSM in diabetic wounds, and it usually takes 3 to 4 weeks at 2 to 3 treatments a week. It's pretty extraordinary, even when the wounds are 2 to 3 years old. And peripheral neuropathies, the numbness and the pain that comes with diabetes comes because the nerves are not getting enough blood, because the blood supply gets blocked by inflammation in the nerves. So this was sensory loss in 7 out of 10 test areas on the bottom of his foot. And you can see that on the second, he was numb in 7 out of 10. On the 10th, it improved. And a month later, he had totally normal sensation and no pain in his feet. If you are a diabetic or you treat diabetics or you know patients who have diabetic foot pain, that would be extraordinary. There are no drugs involved. The nerves and the blood vessels simply recover. So diabetic patients take ongoing treatment, so you get them better in the office, and then depending on their blood sugar control, you have to treat them about once a week to keep their sensation normal. We do have home units, both the home care and the custom care, that can available that are programmed with the FSM protocols to help diabetics maintain control, sensation, and heal wounds on an ongoing basis at home. So here's another old problem in medicine, inflammation, right? Inflammation is at the heart of every degenerative disease, and immune system activation is at the heart of every degenerative disease, including heart disease, irritable bowel, lung disease, Alzheimer's. All of the degenerative diseases have at their source inflammation. So the problem with anti-inflammatory drugs, and we have pretty good anti-inflammatory drugs, they take too long, right? They take a month to work. I mean, your pain goes down in a couple of days, but in terms of long-term immune suppression and anti-inflammatory action, take a while to work. There are too many side effects. It increases the incidence of heart disease or heart attacks. If you think about, what was the one that was taken off the market? One of the COX inhibitors. It affects the gut. It affects the kidneys. There are side effects to anti-inflammatory drugs, and the cytokines are a class of inflammatory peptides that are hard to change. And the drugs that they use for cytokine reduction drop the cytokines below normal, and so the patients are more inclined to get cancer and infectious disease. So here's the thing. What would happen to this inflammatory problem if you could reduce lipoxygenase-mediated inflammation by 62% in 4 minutes? Not 24 hours, not 48 hours, but 4 minutes. What would happen to cyclooxygenase-mediated inflammation if you could reduce COX-mediated inflammation by 30% in 4 minutes? So lipoxygenase reduced by 62% in 4 minutes, COX-mediated reduced by 30% in 4 minutes. Well, we have an animal study that was done at the University of Sydney in the Animal Science Department in 2003. By Vivian Reeve and Wayne Riley. They used the frequency combination, 40 hertz on channel A and 116 hertz on channel B. They paint arachidonic acid on the mouse's ears, so this is a little hairless mouse right there. Paint the arachidonic acid on the mouse's ears, then measure the swelling that's created by the arachidonic acid. And arachidonic acid follows a lipoxygenase-mediated pathway to create inflammation. Myristoyl stearate follows a COX-mediated pathway to create inflammation. And they used 40 hertz on channel A and 116 hertz on channel B. And Wayne Riley, that's him, treating the mouse. Here's the graphite gloves conducting the current. This is our old blue box. It's an analog 2-channel microcurrent machine, 3-digit specific. And there's Wayne grabbing the little mouse by the tail and the scruff of the neck and treating him. And what happened was they had the inflammation went down by 70%, at which point Vivian Reeve shut down the experiment because in 20 years of doing this kind of research, she'd never tested a prescription or non-prescription drug that reduced inflammation by more than 45%. So she blinded everybody in the lab. I mean, not literally, but she moved them all into separate rooms and closed the doors. The guy that was treating, that was painting the mice, the guy that was measuring the mice, the Wayne that was treating the mice, she turned the machine away from Wayne and put in a placebo frequency. And with everybody being super careful, she got a 62% reduction in LOX-mediated inflammation and a 30% reduction in COX-mediated inflammation, which doesn't sound that great, except that it's equivalent to injectable Toradol when it was measured by the same researcher in the same animal model. And Toradol is what they give you after surgery to reduce inflammation. All of the animals responded. That was good news. There is no mammal that doesn't respond to this frequency combination. And we found out in 2003 that it was a 4-minute time-dependent response. So half of the effect was present at 2 minutes. The full effect was present at 4 minutes. So we also wanted to find out, well, would the current by itself increase inflammation? Maybe it isn't a frequency-specific response. Maybe it's just the current. So we ran 1/10 of a hertz. She ran. I wasn't there. She ran 1/10 of a hertz. That gave no reduction in swelling. She ran other frequencies from the list, a frequency to reduce mineral deposits in bone. It's like, will any frequency create this effect? And the answer was no. 4 minutes of frequencies to reduce mineral deposits in bone gives no reduction in ear swelling. There were 4 minutes of a protocol we call the intermediate injury protocol. Back then, that's what we called it. And that gave no reduction in ear swelling. And then both channels have to be correct. So 40 hertz reduce inflammation on 355 hertz for channel B gave no reduction in ear swelling. 40 hertz on A and 116 hertz on channel B reduced inflammation by 30% and 62% respectively. And 355 is the frequency for the skin. And 116 is the frequency for the immune system. So reducing inflammation in the immune system, if the frequencies are correct, produced a huge reduction in inflammation. Reducing inflammation in the skin did nothing. So this one's a little more complicated. They sunburned the mice. I know. At this point, I'm feeling pretty sorry for these little mice. Anyway, so they sunburn the mice, expose them to UV, and that causes, you know, sunburn. You've had a sunburn. It's red, it's swollen, it's sore. Ouch. So they sunburn the mice, and this is the amount of swelling at 21, 23, 25, and 27 hours. Is about 92, 93 units of swelling at the 27-hour mark. And they had one group of mice that was treated immediately after the sunburn, and they had some reduction in swelling, but not very impressive. It was not statistically significant. There was a group that was treated at 2 hours after the sunburn, and they had a statistically significant reduction in swelling. 0.05, 0.01 is actually pretty good. So that's at 27 hours. So that was encouraging. So the thing about sunburn that I didn't know before Vivian was that sunburn suppresses the immune response, and they painted a contact sensitizing agent on the hind leg of the mouse at the time of the sunburn, at the time of the UV exposure. Okay, so 2 weeks later, the same agent was painted on the ear. So contact sensitizing agent is something you should develop an allergic response to. So it was painted on the hind leg at the time of the UV exposure, and 2 weeks later, it was painted on the ear. The normal response to this contact sensitizing agent at the 2-week mark was 30 units of swelling. That's this little purple bar here. It's a normal response in a mouse that has not been sunburned, about 31 units. Okay, so you sunburn the mouse, right? And you paint the oxazolone on his ear 2 weeks later, and what happens? Well, the sunburn suppressed the immune response by 63.4%. IS stands for immune suppression. And the sunburn suppressed the immune response by 63%. Then they had the group that was treated at 2 hours with microcurrent, and the one that had the statistically significant reduction in swelling, that group had their immune suppression, IS is immune suppression, reduced from 63.4% to 57%. That's pretty good, right? About 6% reduction. But here's the mind-boggling part. The group that was treated immediately with microcurrent that had no statistically significant reduction in swelling, that group had their immune system suppression reduced by half, from 63 to 31%, 2 weeks after the current was applied. So they sunburned the mice, painted oxazolone, treated the mice either immediately or at 2 hours, and then they painted the oxazolone on the mouse's ears 2 weeks after the microcurrent and 2 weeks after the oxazolone was applied, and the immune suppression was reduced by half. What that means is that a single 4-minute application of one and only one frequency combination reduced or changed not reduced, but changed immune system function permanently, right? So what are the implications for this for you if you're a patient, or for your patients if you're a practitioner? Well, lipoxygenase and cyclooxygenase inflammation are associated with all degenerative conditions: asthma, emphysema, irritable bowel, Crohn's, pancreatitis, ulcerative colitis, liver disease, rheumatoid arthritis, and degenerative arthritis. And we have case reports and clinical success in all of these conditions. Can't put tissue back that's not there. So COPD, we can slow the progress. Treatment can slow the progress. We just can't put tissue back that's not there. But all of these conditions have been shown to improve clinically with the use of frequency-specific microcurrent by trained practitioners. So here's the thing. What would happen if you could reduce all of the inflammatory cytokines in 90 minutes, but they all stopped in the normal range? So all of the cytokine-lowering drugs take 3 to 4 months to work. Okay, 2 to 3 months to work. And the problem with those drugs is that they drop the cytokines below the normal range. TNF-alpha and interleukin-1 especially, they drop them below the normal range, so the patients are then susceptible to both cancer and infectious disease. So any treatment that couldn't reduce the cytokines in 90 minutes would be extraordinary, and that is exactly what frequency-specific microcurrent does. One and only one frequency combination does this. So the data we have on cytokine changes was accumulated in the treatment of fibromyalgia associated with spine trauma. We did 54 fibromyalgia patients with a history of trauma. They were about 9 years chronic, right? I had blood sample data on a subset of 6 patients. We actually had 13 patients, but there were only 6 patients that met the inclusionary criteria for this paper on fibromyalgia. This group did not, the group of 6, did not differ in either age or chronicity. There was a control patient who had just myofascial pain from trigger points. 28% of fibromyalgia patients have their fibromyalgia from some sort of traumatic injury to either the neck or the thoracic spine. That means there's 2 million patients in the U.S. alone, in the U.S., that have full body pain, rated at around a 7 on a 0 to 10 scale. And what we found with this group, so this is 2 million people, right? We found one frequency combination, 40 hertz on channel A, the frequency to reduce inflammation, 10 hertz on channel B is the frequency for the spinal cord. That took their pain from a 7.4 to a 1.3 in 90 minutes. That alone is extraordinary. That p-value, that statistical measure, has actually 6 zeros. Published paper has only 3. But if you do the math, it's actually 6, which means there's absolutely no chance that somebody with 8 years, 7 years chronic pain could go from a 7 to a 1 in 90 minutes just on time points. Recovery from fibromyalgia is individualized. They had FSM in the office. FSM is a home unit, a certain percentage of them. At physical therapy, reconditioning, they had supplements to help heal their gut and their adrenals and treat their interstitial cystitis with FSM. And the treatment involves putting a contact at the neck and a contact at the feet, and you run 40 hertz on channel A and 10 hertz on channel B, and that is the only frequency that will reduce their pain. Anything else doesn't work. We tried it. And this is what happened. I did this case report, presented this case report at NIH and in 2000, and said to the group, it's like, okay, I've done this 25 times, and absolutely nobody is going to believe it unless we have something objective we can measure. You guys are the best scientists in the world. Somebody help me find something we can measure. So Terry Phillips was a micro-immunochemist at NIH, and he was new there, so he didn't know he was about to break a whole bunch of NIH regulations. And he sent me some blotter paper and asked me to treat a patient and collect blood spots from before the treatment, then during the treatment, and at the end of the treatment, so we could look and see what happened in the blood. And this is what happened in the blood. Interleukin-1 is a peptide. Cytokine is a peptide that's associated with inflammation. Interleukin-1 on this patient, at the end, the first patient I did, went from 392 down to 21. The group is an average. The sick patient, 6 patients went from an average of 330 down to 80. That p-value has 3 zeros. It is huge. It is a huge, statistically significant response in such a small group of patients. TNF-alpha. TNF-alpha in this index patient, this first patient went from 299 down to 20. And once again, that is a huge decrease in a very short period of time. Cytokines, when they change very slowly. They change over 30 to 60 to 90 days. They certainly don't change in 90 minutes. This is unheard of in medicine. Go from 300 down to 20 in 90 minutes. TNF-alpha, this patient didn't respond. Her pain didn't come down, but her cytokines still came down. And everybody else, their cytokines dropped at this rate. Interleukin-6, also associated with inflammation. Index patient went from 204 down to 15. And look at the scatter in this group of 4. There's no scatter. This patient didn't respond. Her pain didn't come down, but her cytokines, interleukin-6 came down a bit. The group as an average, even with this outlier, went from 239 down to 76. That p-value has 0.008. This is huge on a sample of 6 patients. Substance P is produced in the spinal cord. So if substance P goes down, it says that the frequency 10 hertz is indeed changing the function and chemistry in the spinal cord. So substance P went from 132 down to 10 in 90 minutes. That is by a factor of 10, more than 10 times. It's a huge response. The p-value has 3 zeros in a t-test. And substance P stopped in the normal range. All of the cytokines stopped in the normal range. Endorphins go up by a factor of 10, more than 10 times. And the patients about the 30 to 40 minute mark are so stoned, for want of a better word, that they actually can't speak. They would prefer not to. They can be awakened. They will open their eyes, but no, they just want you to go away and leave them alone. By the time you get to the end of it, they're so dwarfed, they really just want you to go away and let them sleep. It's characteristic of a frequency, any frequency that works, is the patients get pretty floaty, and there's no better way to describe it than they just get really stoned. This floaty, and Jeff Bland calls it an induced euphoria. Cortisol went up by a lot, by a factor, by 10 times, right? But it's not a stress response because neuropeptide Y in the blood samples actually dropped, and cortisol just simply follows the endorphins, because if you're going to increase endorphins, you're increasing pro-opiomelanocortin, which will increase ACTH, and beta-lipotropin, which gives you endorphins, and the ACTH is going to cause the cortisol to go up. So it's not a stress response, it's just a side effect of the endorphins going up. Pain score went from 7.3 to a 1.3. That p-value actually has 6 zeros, but the statistician is British, and he said anything more than 3 zeros is shown off, so we only published the 3. All patients experienced pain relief. 58% of them, 31 out of the 53 patients in the study, experienced resolution of fibromyalgia within 4 months. Fibromyalgia is treatable. These patients recover within 3 to 4 months. Tender point sensitivity goes down, they start sleeping, they have improved digestion, improved immune system response. One patient relapsed. What's interesting is 13 out of the 53 discontinued treatment for reasons not related to treatment side effects. And we actually think that it's a psychological issue, that if you've been in pain for 12 years and your pain goes from a 8 out of 10 or 7 out of 10 down to 0 in 90 minutes, at the end of 90 minutes, you really don't even know who you are anymore. This is a fibromyalgia patient who recovered. She was 18 years chronic. She had 14 of 18 tender points December 8th, 11 of 18 tender points 1 month later, and 7 of 18 tender points February 8th. And at that point, she no longer met the diagnostic criteria for fibromyalgia. I called her 6 years after this. I think she was in 2000 or 2001. And I called her 6 years later, and she was still improved. She no longer had fibromyalgia. She had recovered. Her digestion improved. Her IBS resolved. She was off of sleeping medication. She took an occasional muscle relaxant, an occasional pain pill. But basically, she was a normal patient at the end of it. So functional medicine is a modern approach for the old problems in medicine. It looks at why you have the symptoms that you have, why is your immune system activated, why do you have an autoimmune condition, why do you have inflammation. And they use supplements, diet and lifestyle changes to change your chemistry and help correct why you have asthma, irritable bowel, Crohn's, headaches, whatever. And functional medicine is, to my mind, the most effective way of practicing medicine and getting patients better. But there's a problem with it. It takes too long. It takes 3 to 12 to 14 months to turn the physiology around and make the patient better, like so you no longer have IBS, Crohn's, asthma. So it takes too long, and it costs too much. Supplements and the slow response is a problem for patients. FSM, as you saw with the mouse study and the cytokine study, creates immediate responses, but FSM, frequency specific microcurrent, needs a functional medicine approach to get the treatments to last. So here's another problem in medicine: nerve pain, muscle pain, scar tissue. The treatment in the medical world, physical therapy, exercise, injections, treatment for nerve pain, muscle pain, and scar tissue takes too long. It costs too much. It is painful or has significant risk involved if you're doing injection therapy for nerve pain. And it's not very effective. It doesn't work real well, and it's risky. So these are problems when it comes to pain patients. The best and easiest thing that FSM does is to treat nerve pain. Nerve pain's easy. There's one frequency combination, 40 hertz on channel B, A, 396 hertz on channel B, the frequency for the nerve. And no, I don't know how they decided that 396 was the frequency for the nerve. I published a paper on 20 patients. The average chronicity was 7 years, so these people have been in pain quite a while. All patients experienced pain reduction. First treatment, they came in at an average of a 7 and left at an average of a 2, which is really pretty good. Second treatment, they came back at a 4.8 or 5, which is up a bit from a 2, but it's still not back to a 7. And they went from a 5 down to a 1 at the end of that second treatment. 65% of them fully recovered in 5 treatments after being 7 years chronic, no adverse reactions. Every patient experienced pain reduction. 25% of these patients terminated care prior to recovery. So it's a very small group, but the p-value in this is still statistically significant because the changes in pain happen so fast and they are so huge. The first paper I published was in the area of myofascial pain in the head, neck, and face. 50 cases. They were published in 1998. 5 years average chronicity. The range was 1 to 28 years. 88% had failed with other treatments. So even though it was not placebo-controlled, the patients formed their own control group, because if they were going to have a placebo effect, you figure that they would have had it with one of the 6 previous practitioners that had treated them. So 88% had failed with other treatments. It took 11 visits in 8 weeks to get them from an average of a 7 out of 10 to an average of 1.5 out of 10. And that doesn't sound so great. That's a long time, 11 visits in 8 weeks. It took that long because I didn't know what I was doing. I was treating it as if it was the muscle. And what we found in cervical myofascial pain is most often it's the disc, the ligaments, and the facet joints. So when we treat those, these cervical patients these days now recover much more quickly. Lumbar myofascial pain, 23 cases were published in JBMT. This is chronic low back pain. 8 years chronic chronicity, 8 years average chronicity. Range was about 2 months up to 20 years. 87% had failed with other treatments, so the patients formed their own control group. If they were going to have a placebo effect, they would have had that placebo effect with one of the 6 other people that treated them before they got to me. This was 6 visits in 6 weeks to bring their pain from an average of a 7, 6.8 out of 10, down to a 1.6 out of 10. And we just got lucky. All of these patients were really just myofascial trigger points in the psoas, the rectus abdominis, and the lumbar paraspinals. And chronic low back pain is a huge issue in the U.S. and around the world. So if you can fix it in 6 visits in 6 weeks, that's pretty amazing. This was a burn center project. We did 8 patients at the beginning, and we had 7 patients at the end. The PTs measured them on Monday and on Friday. I treated them for an hour apiece, Tuesday, Wednesday, Thursday, and then they were remeasured every week for 2 months. And every patient had statistically significant permanent increases in range of motion after 3 one-hour treatments. This is an extraordinary experience and an extraordinary experiment. Yeah, it's amazing to take a patient's range of motion in their knee or their ankle or their elbow or their neck and double it in 60 minutes. It was an extraordinary experience. Abdominal research, this was done at Baylor Medical School with David Weissman. He induced abdominal adhesions in a rat, and 1 week later we operated on 3 rats, anesthetized obviously rats, and treated those adhesions, and what we found was that I used 5 different frequencies, and there's one frequency and only one that literally turned this cartilaginous white hard adhesion into a liquid. It turned it from white and hard to snot. It turned it to a clear mucose-like substance, polysaccharide. So the implications for that and our experience with that in pelvic pain and abdominal adhesions are quite extraordinary. This is Kim Pittis. She is an FSM sports instructor. We have FSM sports. If you look on our website, you see her course. She's doing a course in Columbus, Ohio in sometime this spring. Sorry, I don't remember the date.
It's on the website.
It's on the website, frequencyspecific.com. And so you combine FSM to dissolve the adhesions and dissolve the scar tissue with manual therapy. So those of you that do physical medicine, this is awesome. If you're treating visceral conditions, you actually don't have to do manual therapy. The frequencies do what they do. So the frequencies were developed in the early 1900s. We already went through this story. The 1920s equipment was not microcurrent. I don't know how the frequencies were derived. We only know that they work. So I've been teaching them since 1997 up until the present, resurrected in 1995, and we're probably 3,000 FSM practitioners worldwide in 8 or 10 countries. And the clinical response is very frequency specific. So the frequency to reduce inflammation reduces pain, reduces redness, reduces swelling, does not change range of motion. The frequency to reduce scar tissue and fibrosis dissolves the scarring, increases range of motion, doesn't reduce pain, doesn't reduce redness or swelling. Frequency to reduce hemorrhage or stop bleeding, stops bleeding and pain in the menses, and prevents bruising in new injuries. So patient that has a hip replacement, you treat them within 3 hours after the surgery, and they don't bruise. They don't bruise. If you've ever seen a hip replacement patient, they're black and blue from their hip to their toes. There's a frequency for mineral ion deposits, softens the tissue, reduces the pain, some improvement in range of motion, but mostly it just makes things softer and less crunchy. Frequency for shingles reduces the pain and eliminates lesions and pretty much cures shingles in about 4 hours instead of 6 to 10 weeks. Frequency for kidney stone pain has been effective in every case of kidney stones, but it's not good for the stone itself, and it's not good for any other condition. So I actually have a published paper in shingles, practical pain management in 2010. There's shingles in the ophthalmic branch of the 5th cranial nerve, so up on the head and on the eyelid and the side of the face, 85-year-old man. There's only one effective frequency combination, 230 hertz on channel A and 430 hertz on channel B. And the patient is pain-free in about an hour. It takes these days it takes about 6 hours of treatment. The virus appears to have mutated. And the lesions are gone and about dried up the next day and pretty much gone in 2 to 3 days after that. The pain does not come back and the patient does not develop post-herpetic neuralgia. And the reason that this single case was publishable is that everybody knows that shingles in the ophthalmic branch of 5 in an 85-year-old man does not get better. It turns into post-herpetic neuralgia, and it is what the patient has for the rest of their life. And this man was pain-free within an hour, and it was permanent. So how do the frequencies change conditions in specific tissues? Well, we're going to speed through this because I'm running a little bit behind, but we started a little bit late, so that's all right. So how does this work? It's reproducible magic, but you want an intellectually satisfying model for how the frequencies could actually change conditions in specific tissues. So basically, the short version is that the human body is a quantum biological system. Living tissue is biochemicals, right? Okay, what are biochemicals made of? Well, they're made of molecules. What are molecules made of? Atoms. What are atoms made of? Subatomic particles. How is all of this hung together? How does it hold together? Well, all of your tissue is held together by electromagnetic bonds, right? Every bond, every electromagnetic and chemical and mechanical bond has a resonant frequency, a frequency at which it resonates, where a small input of vibration or frequency has a huge response in the tissue. So basically, your body is an electromagnetic system that looks solid, but the cells function as a semiconductor network. Water molecules line every cell and tissue in your body, and the water molecules vibrate and form something that is best compared to a silicon chip that you find in your computer. So your body is a semiconductor. Read Jim Oshman's book, Energy Medicine, The Scientific Basis. The second edition is absolutely brilliant. So what you need to know is your body conveys current, charge, and vibrational information. Your cell membrane receptors are sensitive to signaling. These membrane protein receptors determine how your cell functions because they change genetic expression inside its cell by activating kinases, and that activates kinases or peptides that activate transcription factors that change what your genes do, that change whether your cell produces inflammation or anti-inflammation. So that's how the cytokines are created, is that there's some stimulus that causes the genes to change their signaling and change their cell function. So the receptors change cell signaling and cell function. Okay? So resonance, biologic resonance, explain the effect on living tissue. Drugs and nutrients act like keys in a lock. We're all used to that. Drugs and nutrients act like keys in the lock to change membrane receptors, and that changes intracellular function. So when you take an Advil, it's changing genetic expression in the cells, and it stops lipogenase or cyclooxygenase related inflammation, okay? We're used to that. The frequencies act like your key fob. Opens the same lock, this lock. Your key fob opens the lock on your car door, not with a key. The key fob opens your car door lock with an electromagnetic signal. The frequencies act as if they change membrane protein configuration and cell function electromagnetically. It acts as if, the frequencies act as if they dissolve scar tissue cross-links and simply dissolve the scar tissue. And the scar tissue, once it dissolves, in general, doesn't come back, unless there's something to drive it. It acts as if it simply disassembles the shingles virus. There's the only thing that explains what we do in shingles. It acts as if it changes cell signaling. The frequencies act as if they change cell signaling in such a way as to reduce inflammation at logarithmic rates by factors of 10 and 20 times in 90 minutes. That a single frequency combination changes cell function in such a way as to reduce lipoxygenase-mediated inflammation by 62% in 5 minutes. It's extraordinary. You can't throw out the data because it doesn't match your model. So our model now says that these frequencies can reduce the effects of inflammation and change cell signaling and cell function with a frequency, just like you can open your car door lock with your key fob. So how do you use FSM? How do you learn about it? There is a textbook for practitioners, although we have a lot of patients that have purchased it as well. Frequency Specific Microcurrent in Pain Management. It was published by Elsevier. It teaches you how to use FSM in all of the physical medicine conditions where it's effective. The Resonance Effect is a new book. It's coming out April 24th. It'll be available on Amazon. It's on Amazon now as a pre-order. The Resonance Effect, How Frequency Specific Microcurrent is Changing Medicine. The reviews have been awesome. This is a can't-put-it-down page-turner of a book. It is fascinating, funny, inspired, exciting, and altogether delightful. That's from Jim Oshman, who wrote Energy Medicine, The Scientific Basis, and wrote the foreword to the Resonance Effect. I really had this tells a story of how we took the frequencies from a list in a drawer in 1946 to a technique for treating patients with all sorts of conditions in 20 years. It's been quite a journey. Frequency-specific microcurrent is taught in a 3.5-day seminar. It's 26 hours. It's a new tool that helps you solve old problems as a practitioner or as a patient. You can go to our website to get the seminar schedule. It is 3.5 days that will change your life. Well, once you've been there, you actually can't go back. There's 7 practicums where you actually get to experience the effect of the frequencies. You work on each other. You treat muscle pain, nerve pain, whatever people have. The seminars are absolutely an extraordinary experience. You can take them as a DVD course. distance learning, and then do a practicum with one of our trained instructors. Go to the website, www.frequencyspecific.com, and I have to warn you ahead of time, Frequency Specific Microcurrent will change your life. It will change your practice if you're a clinician, and your outcomes. And once you've been to a seminar, you don't get to go back. It will change your life, your practice, and your outcomes forever. If you're a patient, it will change your health and your comfort level forever. This is Dr. Carol McMakin. Thanks for joining us, and visit us at frequencyspecific.com. Take care, and we'll talk to you in April.